Hello, everyone. Welcome to Elevate, GE Healthcare's educational webinar series. Thank you for joining us today. My name is Dr. Arlene C. Rayodica, and I'm the Clinical Education and Applications Leader for ASEAN, Korea, Australia, and New Zealand for Patient Care Solutions at GE Healthcare, and I will be facilitating today's webinar. Our topic for today's webcast is Optimizing Analgesia Monitoring with Surgical Pleth Index, or SPI. What can we learn from an expert? Today's session will be delivered in just a moment by our speaker, Professor Dr. Matthias Lars Grunewald, MHBA. Before we begin, we want to cover a few housekeeping items. On your screens are multiple application widgets which you can use. I will briefly cover the most important ones. During the webcast, you can submit questions through the Q&A widget. We will try to address as many questions as possible at the end of today's presentation. If you are facing technical issues, please do type in your questions in the Q&A widget as well. The On24 technical team will address your issues from there. For the best viewing experience, we recommend using a wired internet connection and closing any programs running in the background. Lastly, this webinar recording is the exclusive property of GE Healthcare. No part of the following content may be copied or reproduced without prior written permission from GE Healthcare. Now, without further delay, I'd like to introduce our webcast presentation, Optimizing Analgesia Monitoring with Surgical Pleth Index. What can we learn from an expert? To be presented by Professor Dr. Matthias Lars Grunewald. Professor Grunewald has been the chief physician at the Clinic for Anesthesiology and Intensive Care Medicine at the Evangelical Amalie Civic King Hospital since October 1, 2022. He studied medicine at Charité Berlin and completed his training as a specialist in anesthesiology at the University Medical Center Schleswig-Holstein, UKSH in Kiev. Professor Grunewald is specialized in hospital management and has been the Deputy Clinical Director at the UKSH in Kiev since 2017. With more than 160 publications and clinical investigations of medical devices and parameters, including Surgical Pleth Index or SPI, Professor Grunewald is one of the most acknowledged physicians who can bring theory into practice and support peers in advancing patient care. Some conflicts of interest of Professor Grunewald: he has conducted research within the topic of anesthesia monitoring for more than 20 years. He has published more than 100 peer-reviewed publications. He has received honoraria for lectures from various medical companies, including GE Healthcare, and he has no patents, no stocks, or other financial involvements with medical companies. In today's webinar, Professor Dr. Grunewald will talk about Surgical Pleth Index parameter and its related clinical evidence, as well as discuss tips and tricks for its use during clinical practice. He will also talk about the clinical advantages achieved by combining Surgical Pleth Index and depth of anesthesia entropy monitoring, and how we can optimize patients with these parameters. This webinar is designed for all clinicians wishing to update their clinical knowledge on the topic. A live question and answer session with Professor Grunewald will follow the webinar. And now, without further ado, Professor Grunewald, the floor is yours.
Good morning, everyone. Thank you, Arlene, for the kind introduction. It's a beautiful spring weather here in Hamburg at the moment. So wherever you're joining, I hope you have the same nice weather outside, and thank you very much for joining this webinar today. The topic we're talking about is death of anesthesia, and how can monitoring death of anesthesia change our clinical practice. When we talk, or when I talk to colleagues and ask them, what do you think is meant by monitoring death of anesthesia? Mainly one component has been said to be important, which is unconsciousness and amnesia. However, I think that when we do our anesthesia practice every day, we are using more than hypnotics influencing unconsciousness and amnesia. However, we are not yet able or used to monitor all of the the pharmacodynamic drugs that we use. So we have subcortical components, also important and very interesting to monitor our anesthetics during the anesthesia practice. Well known is the monitoring of immobility, which we do by certain neuromuscular monitoring techniques. I'm sorry. And but the monitoring of the opioid effects of anti-nociception is not very used yet. With regards of the components of anesthesia and what we do want to affect and what we want to avoid, there's a quite old publication by Bernd Urban from the Bonn University, very interesting and very informative, is that we want to induce amnesia, we want to induce unconsciousness and myorelaxation, and of course we do want to induce analgesia. On the other side, very importantly, and especially during the last decade, we talk about cardiovascular instability and the effects of cardiovascular instability or morbidity and mortality in our anesthetic patients. On the other side, overdosing anesthetics also induces emesis and shivering, which we do want to avoid in any patients that we take general anesthesia. We are today able to monitor all those important components, and on the other side, on the one side, we are very used to monitor cardiovascular stability. Our monitors have really changed during the last 50 years. We as anesthesiologists, we are so much used to that we cannot actually perform anesthesia without them. Neuromuscular monitoring should be mandatory in any patients that have neuromuscular drugs been used. And with respect to hypnosis and nociception, therefore talking about death of anesthesia, I think we still have to challenge this topic. When we look at the individual patient, we see that we have a certain response to our anesthetic effect site concentration. And the response has a quite inter-individual variability in the patient. During our procedure, however, we want to be in the optimal range of the response suppression in our patient. And therefore, we also have to take into account avoiding overdosage of anesthetics and underdosage of anesthetics. And during the procedure, there are differences in suppression with respect to the stimulation intensity. So it differs when we have low stimulation intensity, and we see this in everyday practice during induction of anesthesia, and then the maximal stimulation of our surgical stimulation during the case. However, we do have to be in the optimal range of our anesthetic at each time point, and that makes us a challenge in everyday practice of our daily routine. Here I show you a case that has been published a couple of years ago, just showing you that our anesthetic practice has different physiological effects. Here we see patients with different induction speed of propofol. And the red line, you see that what happens mainly probably in our all clinical practice. We have a regular induction of propofol, and we see a paradoxical excitation during the induction phase of anesthesia. This could be totally avoided if we do a slow induction, in this case, a very slow induction taking a couple minutes. However, we see the beta ratio is totally different, therefore the physiological effects are different. And same things happen with opioids. We see different, I'm sorry, we see different effects of the opioids, either using no opioids or different dosages of opioids, and increasing propofol in our patients. And the pattern changes. As you can see here in the high remifentanil concentration, the beta ratio is different than in patients that are more awake than these patients on the right side. So dosing our anesthetic makes really a challenge, and that is important that we have monitoring in place that helps us dosing them. And of course, we have the fact of cardiovascular instability. We see when we have fast induction that our patients tend to be more unstable. This is because of the vasodilative and negative inotropic effects of our anesthetics. And on the other side, we know that cardiovascular instability affects the outcome of our patients. Therefore, we have to avoid cardiovascular instability. And that is another important fact when introducing our anesthesia. And we need help in being on the right dose, not overdosing the patient, and not inducing cardiovascular instability. When you look at risk factors for cardiovascular instability, we see that the propofol induction is one of the main risk factors. And also the opioids have a significant effect on the cardiovascular instability. Therefore, it makes really important to have a monitoring in place to avoid overdosing of our anesthetics. Just a clinical hint, how can we start that? With regard to a TIVA, using remifentanil and propofol, I always suggest to use a low dose remifentanil being in place until the patient reports effect of the remifentanil, and we really start propofol slowly, slow enough to have the blood pressure in the right range and avoid hypotension, and monitor the patient, start the relaxation, intubate. I show you later is a case where we see that this is really a tricky task. For the introduction, there are certain studies that we can use, and here we have patients at risk. So this is all cabbage surgery. The induction of anesthesia has been done by fentanyl and propofol. We use neuro monitoring, EEG monitoring here, state entropy and the state response entropy difference for the induction phase. And what we see is when we compare, the red line are the patients with the monitoring in place, and the blue line is the comparison group that we see by just using clinical signs. We have a higher drop in blood pressure. The mean arterial pressure significantly drops more than when we use the monitoring, and we can use less propofol when we do the induction using the monitoring. Another study, more taking care of the maintenance phase during anesthesia, using entropy, we see the cumular doses of propofol, of the opioid sufentanil. The sufentanil consumption in the entropy group is lower. And of course, because it is monitored, we see also a reduction in vasopressor use, so more stable anesthesia. It is really challenging to keep the depth of anesthesia in the right place. And this is just a look into the future, because how can we adapt anesthesia? We see here a group that used closed loop monitoring, so a computer system guiding to be in the correct range of the monitoring. And this is much more easier, and the percentage in staying in the target zone is higher in the computer controlled closed loop group. in comparison to the manual group, where we only are in 60% of the time within the target range seen here for the state entropy being 40 to 60. So in the future, I'm very convinced that those systems will help us dosing our hypnotics and also the analgesic, the opioids, to be in the correct and optimal dose range of our anesthetics. Does this guidance by entropy also give us an advantage in the emergence of the patient? I think so. Here again, we have risk procedures, we have VATS procedures, thoracic surgery, again, propofol and fentanyl for induction. And in this case, we have a balanced anesthesia using the volatile sevoflurane with the target range of state entropy 40 to 60. And we see advantages in the avoidance of overdosing the anesthetic. We see here the time percentage of the response entropy being lower than 40, which is in the entropy group only 1.9% of the time. And we see in the clinical guidance group 10%, so almost five-fold higher percentage to have higher too deep anesthesia being in place without the monitoring. And I told you we are talking about emergence. We see advantages here. We see a much faster eye-opening in these patients. And also we see an effect on emergence agitation. So patients awake much smoother than when we just use clinical signs. We don't know why that is. Probably also the effects of the physiological effects are being in place. So faster emergence and less agitation in those monitored groups. I'm very thankful for those slides that have been provided by Anna Maria Bonetto, older monitoring technique. But you see here in this case, we really kept entropy in the target range, and a entropy monitoring showing such a curve. We have long periods of too deep anesthesia, and these are non-optimized patients that have effects on cardiovascular stability. They wake up the wake-up times are longer, and so side effects that we want to avoid. But is the picture complete by using the EEG as monitoring of the hypnotic components? As you guessed, because of the introduction, no, we need more. We do need to talk a little bit about the opioids dosage in our patients. And quite a long time, an index has been introduced into the clinical monitoring, the so-called Surgical Pleth Index. And I want to talk to you a little bit about the studies about the Surgical Pleth Index and how that can change our clinical practice. When we talk about the nociception and antinociception, various parameters have been introduced into the clinical and research practice. Some of them are using the EEG as a signal. The most of them are more subcortical parameters using the autonomic response of our central nervous system, like the pupil dilatory effect during stimulation, cardiovascular effects, but also others that use our sweat and movement as indexes and variables of anti-nociception. Well, a Finnish group led by Avi Ili-Hankala and Matti Huikku have thought, what can we monitor which is already in place and give us an idea about the anti-nociception component of anesthesia. So they went into patient data and looked at remifentanil concentration and stimulus intensity, and combined various parameters that could be used in daily clinical routine, for instance, blood pressure, heart rate variability, and also just heart frequency and the pulse amplitude. And they found out that when we used the just pulse plethysmographic signal, the combination of pulse amplitude and heart rate may be sufficient to calculate an index, so-called Surgical Pleth Index, giving us a signal of the antinociceptive component of anesthesia. And they found out that adjusting this index by further using the systolic blood pressure, heartbeat interval, pulse transit time, did not further give us advantages in the monitor. So by just using those two components, they had a quite good signal dividing the nociceptive stimulation and also seeing remifentanil effects on this parameter. 2 years later, our group has done the proof of principle during induction of anesthesia. So we went into the induction room and had different anesthesia in place. We looked at TIVA, we looked at balanced anesthesia, we looked at mono anesthesia. And then we challenged our patient by nociceptive stimulation, standardized nociceptive stimulation, and so kind of wanted to show whether we could see the remifentanil effect and the effect on stimulation intensity. And when we did so, we found out that the Surgical Pleth Index response to those Noxus stimulation was better in dividing those effects than our standard monitoring that we do use in everyday practice. So we saw the signal and saw a quite higher increase in the Surgical Pleth Index in patients that showed unresponsible movement or non-movement. We also saw that the effect on the Surgical Pleth Index takes longer in place than in those patients that did not move. We did not see a very predictive effect. So when we look at the SPI before the stimulation, it is quite similar, which makes sense because the stimulation itself changes the balance, and before the balance in all the patient is probably the same. Very interesting again was when we looked at the change of the variable. So therefore the delta SPI, especially in comparison to the delta in heart rate, which we often use in clinical practice to divide and see whether the patient has the right nociceptive balance or not. We could see that all the patients that moved had a delta SPI which was higher than 10. Whereas on the other side, the delta heart rate could not divide between the patients of movement and non-movement, as you see, for instance, in those patients that did move but did not show any change in heart frequency. Whereas we had other movers which had a heart rate increase of more than 30. Therefore, the delta SPI is, in my experience, a much better indicator of anti-nociception than just looking at heart rate or blood pressure, which you only measure intermittently. Here we have a typical induction phase. We see the patient at the start of the procedure. Typically, there is a cardiovascular response when you tell the patient that you now start the procedure. This is a healthy patient. In this place, we started low-dose remifentanil and then low-dose propofol. And you see the effect of those pharmacokinetics. You have here a 5-minute window, and the value drops down to a value of 20, and later on we see an increase here. This increase is due to the rocuronium effect. Rocuronium is diluted into an acid-based solution, and sometimes it really puts a nociceptive input onto the venous system, and you can measure this. So if you see an increase in the SPI value due to your rocuronium induction, this is quite normal. And I told you before that also you can see the optimum of the antinociceptive effect during intubation. You see here a laryngoscopy by a student, a trainee, that was very gentle and could not be performed. However, then the consultant came and did another try, and you saw also that the antinociceptive component, the remifentanil concentration in this patient was insufficient, as we saw immediately increase of the surgical Pleth index, and we could wait a little bit and did another try of intubation, which was much more smooth, with no increase in surgical Pleth index and immediate performance of the airway. Another study being published 3 years ago by a Polish group compared the guidance during eye surgery in comparison to blocks, so retrobulbar blocks, and they suggested that the dosing of fentanyl using SPI guidance was so sufficient that in the future they're not using the block technique anymore. So at the end, they come to the conclusion it's advisable to invest in such a monitoring. I told you before, the monitoring is already there because we have pulse plethysmographic signal in place in our in every patient in our clinical practice. Which patient I suggest the monitoring the most, and this may be surprising for you. I suggested the most for healthy patient, outpatient setting, ambulatory anesthesia, because I think due to the monitoring of the hypnotic and the antinociceptive effect, your processes are much faster and much more sufficient. This is a study being published by a Göttingen group that could show the remifentanil dose was significantly lowered in comparison to the control group, and again, propofol dose was lowered, and very importantly, again, equally to looking at the hypnotic effect, by using additional monitoring, you have an effect on emergence time. You have a much more predictable wake up from anesthesia, and that is one of the main advantages of using those monitoring devices. This is a study we did then with sevoflurane and intermittent opioid bolus of sufentanil. Just want to show you that it makes sense, and we see again the delta value is much more pronounced than looking at heart rate itself in both groups. And we saw that here in the study group, where the opioid is only given when the SPI value raises above the threshold value, that you have a response in the surgical Pleth index, which is much earlier than just looking at heart rate, and you could easily adjust. And in the control group, by just looking at your clinical practice, we cannot see such a dependency when using clinical parameters. You you do that by your experience, but an effect on the surgical Pleth index or heart rate could not be seen in the period before or after the induction of the opioid. After a couple of pilot studies, we did a multi-center trial, which is, to my knowledge, the biggest trial with guidance of anti-nociception by any parameter so far. This is a multi-center study being performed in Amsterdam, in Finland, Tampere, and in Hungary, as well as in Kiel, Germany. And yeah, we had two groups. The one study group where our anesthetics were monitored due to entropy and SPI, and we had the standard care group where entropy and SPI were obscured. We were very surprised because effects that we saw earlier in pilot studies, which was avoidance of unwanted events, could not be shown again. However, when we looked at our data, we again found that we were not exactly in the target range. We were too slow in adopting our anesthetics to be in the target range, which was a protocol issue introduced because we looked at the pharmacokinetic models calculating the effect site concentration, and were only allowed to change again after reaching those effect site concentrations. These kind of plotting can be shown in your daily clinical monitoring again. So it's so-called a balance view, and it facilitates you to be in the target range, which is the gray box showing here. So this is your task in daily practice to move your patient, your dots, into this target range shown here. So at the end, we had to admit that in our study, we could not reach to be in the target zone often enough. And we had long reaction times, and that probably avoided those effects in the multi-center trial. However, we also saw positive effects. Some practical dosing issues from my point is use the EEG and nociceptive monitoring, anticipate the needed balance, do not allow the state entropy to reach values above 60, avoid overdosing and side effects, and we do have to react faster than in our multi-center trial, which really is an issue. And as I shown you before, computer systems helping us in a closed loop way will be the future, avoiding those slow reactions. In all those studies, including our multi-center trial, we see such phenomena. These are emergent, these are plots of the Kaplan-Meier curve of waking up. And in the control group, you often see such a tail here, which includes 10 to 20% of your patients. You see this in multiple studies. And these tails, these are the patients that disturb our anesthesia processes. And using those monitoring devices, you see a much more predictable wake up of our patient. Therefore, it is strongly my advice to use those monitorings in rather healthy patients and optimize your OR processes. I show you now the data from the multi-center trial, and again, we saw a much more predictable wake up in the monitored group in comparison to the control group, and this was even in effect in the post-anesthesia care unit, where the study group had shorter times within the PACU than the control group. There are a newer meta-analysis showing us the effects of the anti-nociceptive monitoring. In those meta-analysis, there are certain different monitors being included, but we see here that we have an effect on the opioid dosage. Your effect is significant, and this is a newer meta-analysis, only 2 years old. Again, we see the opioid sparing effect due to different parameters being studied. And as I showed you before, we also can conclude that we have the faster emergence by using those monitors. This sounds all very positive, but I have to tell you that there are certain confounders that have to be taken into account when using those, especially the Surgical Pleth Index, because it is a value that has been derived by cardiovascular effect. I explained to you the heartbeat interval and the pulse amplitude. This parameter may be influenced and is not feasible to use in patients with atrial fibrillations, high vasopressors, or pacemakers in place. And the values being taken into as our optimum target zone are confounded by other sedating medications, co-medications like clonidine, the positioning of the patient, because that also has cardiovascular effects, and as I showed you, the type of anesthesia. So there are differences between balanced anesthesia settings and TIVA. Here one example that I filmed during positioning. We see now the patient moving up. I'm sorry, the video is not running here. So, yeah. You see an increase in the SPI value due to the positioning of the patient, because the fluid, the intravascular volume is shifted into the legs, and of course the body will increase heart rate, and then later on also pulse amplitude influencing the value, which has nothing to do with anti-nociception, so therefore take this into account. And the same is with pneumoperitoneum. Here we have a constant insufflation of the pneumoperitoneum. You also have a shift into your vascular volumes, showing an increase, just for you to know, making sure that there are disturbances. Here we have the injection of a vasopressor inotropic drug being used in Germany. It's called Acrinor, and you have an increase, and you also see that the signal equalizes very fast. I think that is one of the advantages of the Surgical Pleth Index. The signal stability is quite good to use. I've had research in other variables where I saw much more variability in the signal, make it much harder to use it as a clinical guide. Okay, before I come to the conclusion, of course, I've talked now much more about overdosing than underdosing, but of course, underdosing is also an issue. So from my clinical experience, we've had trauma patients that had a high use of opioids, which could be very easily done by using the SPI monitors. We experienced a young patient giving quite higher doses of anesthetics than we used in our routine clinical practice without those monitoring devices. So therefore, I think these are just single patients, but we do have patients where underdosing is an issue, and this could also be avoided by using those monitors. My conclusion is depth of anesthesia monitoring enables individualized titration of anesthetics. It helps to stabilize haemodynamics, as I have shown you, especially during induction and maintenance of anesthesia. My experience is that as we as anesthesiologists tend to use a lot of opioids because of the cardiovascular effects, but we can use less opioids by monitoring the nociceptive component, and almost all studies show that we have faster recovery in patients where we have depth of anesthesia monitoring in place. I thank you very much for your attendance, and I'm open now for your question. Thank you very much.
Thank you very much, Professor Grunewald, for taking the time to share your expertise and insights. We will now address questions that were submitted during the presentation. At this time, we are only able to address questions that were submitted in English. Additionally, please note that questions and responses may not be relevant in all countries. Professor Grunewald, we do have a few questions here for you. So the very first question is, hi, Professor Grunewald, and thank you for your presentation. If SPI is based on haemodynamic signals, how does its use for analgesia titration change from standard haemodynamic parameters?
Yeah, I think that just looking at haemodynamic parameters, you are too slow in reaction. Of course, by being have a high attention to those parameters, and even if you have continuous variables in place like arterial line, you see those effects also by just using at your haemodynamic monitoring. But using SPI is like a boost of the signal. So you will miss seeing those boosts by just looking at blood pressure intermittently, let's say every 3 minutes. Heart rate, I've shown you, is not a good variable because it's much slower and the amplitude is much lower. Yeah, I think the wording boost is really here the right word. The signal has been prepared for you to have the effect of the nociceptive component, but the one that asked the question is correct. The value SPI reflects the cardiovascular response onto a stimulation. So it is always a reaction of something.
Thank you, Professor. Another question here. You talked a lot about TIVA. Can we use the SPI on balanced anesthesia with sevoflurane?
We did those studies with sevoflurane, and I'm convinced it works very good in combination with opioids. I cannot say much about opioid-free anesthesia, where you use dexmedetomidine or clonidine. That will affect the target range. But with respect to balanced anesthesia, using volatile anesthetics and opioids, it really works. In a study where we did the guidance and looked at the guidance of anesthetic, we used sevoflurane and sufentanil in the intermittent sufentanil bolus. That we saw a tendency of lower opioid use and faster recovery from anesthesia, as shown in the other studies.
Okay. So, Professor, the earlier question was about TIVA. So what about combining it with, so general anesthesia combined with spinal anesthesia? So how can SPI help if it's general anesthesia with spinal anesthesia? And what are the advantages to this?
Whenever you combine your anesthesia practice, general anesthesia with a regional anesthesia also in place, the Surgical Pleth Index may give you the information if your regional anesthesia also works or not. So again, you have another confidence that you avoid your additional opioid. And this has been shown in thoracic surgery. This has been shown during abdominal surgery. So using the SPI just gives you the information that your regional anesthesia, it may be an epidural, it may be abdominal wall block, works perfectly.
Okay. Professor, you were talking about faster reaction time, right, when we're monitoring SPI. So how increase in SPI, and how high should the variability be in the SPI value before we should react to this?
Yeah, this was one of the tricky tasks in our multi-center trial. And I wish we could do it again, but it was a high effort to do this, especially combining 4 university centers throughout Europe. My suggestion would be the signal needs about 20 seconds to calculate and react. So you need at least 20 seconds before you see the change to the maximum in the signal. Whenever you see an increase, immediate increase in those, let's say 20 to 30 seconds, and the delta value is more than 10, then check your patients again. Check whether something happens, pneumoperitoneum, change in the cardiovascular system, is there bleeding, is the positioning of the patient the same? And when you can disclose all that, then you probably have an effect on the anti-nociceptive component. So, and if you already look at all those components, you can conclude that there's something happening with respect to nociception.
Okay, thank you. From what you said, can we infer that if we use dexmedetomidine, we cannot use SPI? Or are there some changes we can learn and still use it?
This is a tricky question where I have no final answer. I think that the reaction, the nociceptive reaction, is been blunted by dexmedetomidine, and we don't know much about the effects. So actually, I cannot answer. I think it's useful to use, but whether this really affects the nociceptive component, probably not. It's more the cardiovascular response. But experts are not sure whether this is sufficient or not. Maybe this is sufficient if we have the non-analgesic reaction of dexmedetomidine being perfect. And I know that a lot of colleagues prefer to share and to avoid opioids by using dexmedetomidine or clonidine.
Mm-hmm. Okay. Professor, we have another interesting question here. When is the right time to discontinue propofol in TIVA for emergence and guide that with entropy?
What we used in our studies is that we lowered the propofol concentration when the main surgical task was finished. So the surgeon tells you that he's now going back and thus begins with the suture. We did allow during this phase values higher than 60. So our goal was entropy values between 60, 65, and 70, which was sufficient. No patient in our study had any recall of the emergence phase. Yeah, I hope that helps answering the question. So this is always, and that is one of our main tasks, being close to the surgeon and know what the surgeon is doing and what the reaction of the patient is. And that is also one limitation of the monitoring. When you know that there is now a pull on the peritoneum, for instance, or another nociceptive input, no monitor can really predict that this is the sufficient suppression of the nociceptive input. The anesthesiologist needs to be in place to react.
Mm-hmm. Professor, we have the last two questions here. So the first one is, since you did a lot of study on SPI, do you think anti-nociception will be part of standard parameter monitoring in the future?
I really hope so. And I only can encourage GE Healthcare to make it available to all the anesthesiologists, because I think it's so useful in our daily clinical practice. So I really hope so. I know that there are other parameters on the market which, in my opinion, have comparable effects. So this is okay, but the main advantage is non-invasive. It's very easy to use. It's just a plethysmographic sensor being already in place that gives us additional information, very, very important information. And I hope that in the future it is in place and helps us guiding anesthesia.
The last question for you, Professor Grunewald. Do you think SPI plays a role in the goals of ERAS?
I think using less opioids is one main goal in the ERAS concept, and therefore this may really help us and being in the correct dosage of anesthetics. As I've shown you in multiple places during my talk, it gives a faster emergence. It has less agitation during the emergent phase. All important points of the ERAS concept. So therefore, it's a clear yes, it is.
Thank you very much, Professor. So there are no more questions. I'm not sure if you've been seeing all the thumbs up signs that our audience has been sending. But thank you very much. I think everybody learned a lot from this session, and they found it very, very helpful. But before we end the session, may I ask all the participants to please give us your feedback by answering the 5-question survey, which will appear at the close of this broadcast. It should take no longer than 2 to 3 minutes to complete. Thank you once again, Professor Grunewald. And thank you, everyone, for joining. See you again soon.
Thank you, Aline.